Well, good afternoon, everybody, and welcome to our monthly clinical conversations session. My name is Barry Sorvette, and I'm the statewide medical director for McPap. And it's a pleasure to welcome you to our session today. As you know, they take place the fourth Tuesday of every month. The next one is May 25th. And that topic is going to be assessment and treatment of social anxiety disorder in children. Today, though, our topic is actually not, very unrelated. It's actually the topic is school refusal, clinical characteristics, functional assessment, and intervention strategies. I'm really pleased to introduce our speaker momentarily. But before we do so, just some housekeeping issues. As you see on the slide, we are offering CMEs with the help of the Mass General Hospital Continuing Education Department. And the CMEs for now are for physicians and nurse practitioners. If you want the CME credit, you have to send a text message to the number that's on this slide. It's 857-214-2277. Today's code that you put in the body of the text is YEWLUD, and that's up on the slide. At the end of the session, you have to complete an evaluation, and then you receive your CME certificate. As always, we record these sessions, and they're available, recordings on the McPap website at www.mcpap.com. We also provide a copy of the PowerPoint slides on the website under toolkits and resources. So we're going to go ahead and get started. The presenter today is Dr. Meredith Elkins. One other housekeeping thing is that because this is clinical conversation, so we want to have dialogue, with you guys, and so we are welcoming and encouraging questions. Enter them into the question function or the chat. We'll keep an eye on the questions. If they're if it's natural to sort of ask our presenter to address them during the presentation, we'll do so throughout the presentation, and some of the questions we'll save for the end. And at the very end of the presentation, we would really appreciate your filling out the survey so that we can get feedback from you and also for planning future presentations. So Dr. Elkins is a licensed clinical psychologist. She specializes in the research and cognitive behavioral treatment of pediatric anxiety disorders and obsessive compulsive disorder. She has extensive training and experience in evidence-based interventions for children and adolescents with anxiety and individual, group, intensive, and behavioral parent training formats. Dr. Elkins has a deep commitment to working clinically with children and families. She's honed her skills through research and training at leading clinical research centers, including the Center for Anxiety and Related Disorders, which is also referred to as the CARD program at Boston University, the Kennedy Krieger Institute, New York Presbyterian Hospital, Weill Cornell Medical School, and the Columbia University Clinic for Anxiety and Related Disorders. She's also the co-program director at the McLean Anxiety Mastery Program, the MAMP program, which is an intensive outpatient program for anxious youth. It provides group-based cognitive behavioral treatment with an emphasis on exposure and response prevention for children with anxiety disorders and co-occurring conditions. So I will turn it over to Dr. Elkins, and thank you so much.
All right, thanks, Barry, and thank you for impressively getting through all those acronyms. It's no small feat. Let me go ahead and get us started here and share my screen. All right. Okay. So welcome, everybody. So I want to just start by reviewing the learning objectives that I hope you will get from today's talks. So first, we want to examine some of the characteristics of school refusal behavior, along with some relevant and impactful contextual variables. Learn assessment strategies to clarify the function of school refusal behavior and to inform individualized treatment recommendations, and then to identify intervention strategies, multidisciplinary approaches, and community resources for youth struggling with school refusal behavior. So kind of brief roadmap for today. I wanted to start by defining school refusal. As Barry alluded to in my background, most of my work is with anxious youth. And so in the Venn diagram between anxiety and school refusal, there's a pretty significant overlap. However, as we'll discuss, not all of school refusal is related to anxiety. However, I think that's going to be the area where I will focus today. So we'll talk a little bit about that. And then what we've seen in terms of the impact of COVID-19 on school refusal. Then I'll steer us into more assessment of school refusal, and then I'll talk a lot about the functional model of school refusal and apply that to some clinical vignettes, and then dive into talking about some strategies and some resources. So seems pretty obvious, but what is school refusal? Well, school refusal is actually a range of behaviors. So related to attending school and remaining in classes, and really meeting age appropriate expectations for school engagement. So we see just a huge spectrum of attendance problems. There can be, on the one end of school refusal behavior, there can be school attendance, but with daily pleas for non-attendance from parents and a lot of stress, and just that school is a tense, difficult place for young folks, all the way to this complete absence from school for an extended period of time. So as you can see, even just by the very definition, school refusal is really heterogeneous in every sense of the word. It's not associated with a single psychiatric diagnosis or a medical illness or a family circumstances. And so it reflects this wide variety of both covert and overt behavior embedded within a broader context. And so to best address the school refusal, it's highly important to consider the context in which the behaviors are occurring, as well as the functions that the behavior is serving for the child. So I'll start by just thinking a little bit about some of the contextual variables to consider. So, first, the child-based contextual variables. So these would include anything from pre-existing medical conditions or psychiatric conditions, learning disabilities, trauma history, any social skills deficits, work obligations out of school, anything that the child is kind of bringing to the table that might represent some challenges in terms of school attendance. Then also we would consider the parent variables. So differences in sort of expectations for attendance and performance, the level of involvement and supervision that the parent provides to the child, whether it's a single parent home, the differences in parenting styles, how much they communicate with the school. Family variables, is this a family that's experiencing intense conflict or chaos? Have there been stressful family transitions like a divorce or unemployment or relocation? Acculturation levels, degree to which the family is struggling with poverty, simple transportation issues. As well, we also want to consider peer variables, so the extent to which the child is really associating with deviant peers or getting pressure from peers for absenteeism. If there's, low involvement in extracurriculars, or if there's evidence of bullying or cyberbullying, that of course can affect school attendance and refusal. Then there are variables within the school to consider. So, we see more school refusal behaviors, more problems with attendance when in school systems where there's frequent teacher absences or changes, if there's kind of this poor connection between student and teachers, and overall a rating of kind of a poor school climate, which really refers to students not feeling very connected with the school. If there's inadequate attention to diversity issues, if there's a kind of a culture of racism within the school, or a dangerous school climate. And then finally, we want to think about community-based variables as well. Is it, is the school located within kind of a safe or unsafe or a chaotic neighborhood? And, for some kids, are there strong economic pulls for them to, work outside of school, spend their hours earning money rather than being in school? So just a lot of things to consider as we move forward. I'd like to distinguish a little bit about, what's a legitimate reason to avoid school versus a not so legitimate reason to avoid school. So of course, true medical illnesses, actual appointments, family emergencies, religious holidays, all of these here would represent kind of a legitimate reason to avoid school. Because we find that school refusal is such a slippery slope, we often find that sometimes kids who have a pattern of school refusal may have had sort of longstanding expectations within the home where pretty much anything goes for avoiding school. So it may be helpful within the context of a well visit to talk about how to make sure that kids are only avoiding school for legitimate reasons. Pre-COVID, when we were working with families of anxious youth, we would talk about, the only real legitimate reasons to avoid school would be, fever, vomiting, or diarrhea in terms of illness. That's obviously changed given the pandemic. But I think that it's really important to think about, is a headache enough of a reason to avoid school, especially because a headache can be one form in which anxiety manifests for kids. And so really thinking toward, how can we help the family come up with guidelines for when the child can miss school and when it would be less advised for them to miss school. That can be really important. All right. So, going off of this topic, many school avoidant youth will endorse somatic complaints, so stomach aches and headaches and sleep problems. So first and foremost, we want to rule out that there's any true medical concern that may be causing some of these problems for the kids, so that we can more appropriately address the school avoidance, from a behavioral or a psychological standpoint. It also may be helpful to provide some kind of reality testing, some cognitive behavioral skills here with families. If the child is often endorsing stomach aches or headaches and then feeling like they can't go to school because of that, thinking a little bit about, well, I wonder if you've ever done something that you did want to do even though you had a headache. Have you ever gone to soccer practice when you had a headache, or did you ever go hang out with friends when you felt kind of nauseous? Or have you ever, been able to get through your homework even though you haven't slept enough? So, making sure that the family and the child understand that just because there is this somatic complaint, that shouldn't preclude school. And I think the reasons why it shouldn't preclude school will become increasingly clear as I talk about the association between anxiety and avoidance, which again is just such a slippery slope that we are hyper attentive to, in the areas where I work. So again, school avoidance and school refusal is not always associated with anxiety and or caused by anxiety, but it's often a key contributor. So I wanted to make sure that we presented and discussed sort of a model of anxiety, how it develops, how it's maintained, because this impacts not only how we conceptualize school avoidance or school refusal for a particular child, but also has impacts treatment. So this is the kind of cycle of anxiety via negative reinforcement. So starting over on the left-hand side, in the event of an anxiety-provoking situation, all of our anxiety symptoms increase, both the physical and the cognitive components of anxiety increase. And what we find is a very, very effective way to decrease anxiety is to avoid or to escape from the situation that's causing that anxiety, and which immediately brings relief. And so that relief has in effect reinforced the fear of the original anxiety provoking situation, so that the next time that anxiety provoking situation emerges, this cycle is more likely to repeat itself. So here's a model that we actually present to our families in our anxiety program, talking about the development of anxiety disorders. And, for this example, let's just use kind of anxiety in the classroom as an example. So you can see that time is along the x-axis and the intensity of the anxiety is along the y-axis. Say the child is sitting in class and starts to notice some anxiety, notice some somatic symptoms of anxiety, notice that anxiety is increasing. And sort of at the peak of anxiety, the child thinks to themselves, I can't be here, I've got to get out of here. And they leave and they go to the school nurse's office. what we would find is that the anxiety would go right down. So the child, by avoiding the school setting, has found a really effective way to avoid their anxiety. However, what happens is that next time they're in the classroom, because of that negative reinforcement cycle, the child is actually more likely to re-experience anxiety and actually experience it to a greater degree, because the avoidance that they first engaged in came with this learning that, oh man, I can't handle being in the classroom. When I feel these panic symptoms, the only way to deal with it is to avoid the situation. So that then sets the child up for a repetition when they engage in the same situation again. So now I'm going back into the classroom. Oh man, here are those panic symptoms. They're increasing again. I got to get out of here. I got to go to the school nurse. Phew, I feel relief. And then again, the cycle sort of continues. It becomes more entrenched, more intense. And so over time, what you see is this repeated, well-meaning attempts to reduce distress over time actually lead to the development of an anxiety disorder, an anxiety problem. And you can see where this would happen just generally with leaving school. Every time the child feels distress in a school setting and goes home, it reinforces the belief that the child cannot tolerate school and needs to leave. So if you take one thing away from this presentation with respect to anxiety and school refusal, please remember that avoidance fuels anxiety. The worst thing that we can do for a child whose school avoidance is motivated by anxiety is to encourage more avoidance, because while that may help in the short term, it's going to perpetuate the problem in the long term. So how we would address this from a behavioral perspective is with exposure therapy. So if you think about, kind of what would we recommend in a vacuum with the kiddo who I presented, who was having panic symptoms in the classroom, what we would be recommending is to stay in the classroom despite the elevated symptoms of panic. And a lot of times kids will be like, oh my gosh, well, if I don't leave and go to the school nurse, aren't my anxiety symptoms just going to go up and up and up and up and up? And, perhaps until I have a heart attack or I pass out, and as we know, panic increases, it peaks, and then it decreases over time. So by actually exposing oneself to the experience of anxiety without avoidance, we learn that it's awful, it's not fun, but you can cope, you can tolerate the anxiety. And so with that exposure comes this learning of, okay, I can deal with this. And with repeated exposure, we find that as the child continues to engage in or be around the anxiety-provoking situation over time, and rather than avoiding at the peak of anxiety, they remain in the situation, then their anxiety will decrease. And gradually, there's this return to baseline where the situation causes less and less anxiety over time. So that's the kind of exposure model that I think a lot of the interventions that we'll discuss today is drawn from. I apologize. I'm sure that's review for many of you, but I just wanted to kind of anchor us all in the same conversation.
Hey, Dr. Elkins,
Yeah.
one of the audience members was asking, you may want to address this later, but just the whole issue about pediatricians being asked for letters and, sort of to have kids excused from activities. And I think it's a common thing that it ends up being a repetitive issue, for certain kids, for pediatricians. And do you have any thoughts as far as how pediatricians can kind of navigate this and handle those requests?
Yes, I feel for you because I've definitely been there. We as psychologists often get requests from families to write letters asking for their child to be excused from certain things. And I have a really hard time doing that without having a concrete conversation with the family about, what would this achieve in the short term and what would this achieve in the long term? So rather than just kind of writing a letter, here you go, I think, to the extent that time and circumstance allow, speaking with the family about the association between anxiety and avoidance and say, what is this likely to achieve? Is this likely to actually make the problem worse? To what extent is your child absence from these activities or from these demands going to snowball over time. And then we are going to talk about, kind of recommendations for outpatient support. But, perhaps you could say, I can't confidently make that recommendation without you all first consulting with, a behavioral health specialist to make sure that we're not inadvertently reinforcing any problematic patterns here. That's a really tough one. I get those questions a lot. I get questions about, can we homeschool our kid a lot? And again, because avoidance fuels anxiety, we really go into that. We really take those requests very, very seriously, and we want to make sure we're not contributing to a bigger problem. It's a tough one.
Thank you. That's really helpful.
Yeah, it's a tough one. So I want to just talk a little bit about the association between, COVID and school refusal. My colleagues and I have been struggling to find some peer-reviewed data showing the prevalence of school refusal behavior in the classrooms these days, because anecdotally it is blowing up, and I'm sure that's why you are here today, because it's blowing up in your offices as well. So there hasn't really been anything published to date that's showing the change in school refusal, but I oversee admissions for our program, and I would say estimations pre-pandemic, maybe 20% of our population was school refusing, or at least some minor school avoidance prior to the COVID pandemic, and now I would say it's around 80% of our referrals. So this has just really become a huge issue. McLean's Child Outpatient Department has a school consultation program, and my understanding from my colleagues in the school consult program is that's school refusal is the #1 issue that schools are looking for feedback about right now. So this is definitely something that we're seeing more of related to the pandemic, and so this is definitely not an evidence-based model by any stretch of the imagination, but this is kind of how we're, at least in our clinic, sort of looking at what we're seeing in terms of the relationship between COVID, anxiety, and school refusal. So often we're seeing youth who had either a vulnerability towards developing anxiety disorders or depression, and or a history of anxiety and depression, and then you have, by virtue of these lockdowns, this prolonged absence from school due to remote learning. And of course, so many children, this isn't to make light of the struggles that children had when they were, they had this forced separation from school, and for some youth, this was, while it was challenging, it was also, a breather. It gave them the opportunity to not face those day-to-day stressors that provoke just this kind of natural level of anxiety. They didn't have to deal with, wondering what it would be like to speak up in class, or, am I getting a sideways look from a peer because I chose to wear whatever today? The academic demands decreased, so there were fewer stressors there. There's just so many things that children have to develop coping skills for in their normal day-to-day experience of school. And so avoidance of that for so long led directly to this lack of in vivo opportunities to develop coping skills. Then in addition, they had the positive reinforcement of staying at home in the form of these tangible reinforcers, more time with Netflix, more time, in my bed, more time with my pets, more time with my parents and my neighborhood, like in my bubble, all of those ways that the home can be reinforcing for some children. And then, of course, there's the negative reinforcement going on. So the avoidance of school increases anxiety about school, which is why Mondays are always the hardest day to go back to school and to work. And coming back to school and to work after holidays is always the hardest. It's just a natural thing. When we're not doing something regularly, it becomes harder to re-engage with. And then, add on to that the fears of school-based COVID-19 transmission. That's something that's percolating for parents and for kids as well. So, all of this kind of seems to be contributing to this perfect storm for what we're seeing right now. So I am going to drive you all nuts with my discussion today about how important it is to assess the function of school refusal, to really start by assessing school refusal. And that's simply because the interventions that we would recommend for school refusal behavior are so dependent on what's driving the the behavior. So if you've got a family coming to you in your office and just saying that their child has been avoiding school, there are a couple of things that you can do first to kind of be a good detective and try to get the right information. So there are some self and parent report forms. Chris Kearney, Kearney, is like the school refusal guru. And so he and his team have published the school refusal assessment scales. There's a child version and there's a parent version. So this, again, can just help to make more objective what families are dealing with. In the absence of having access to those measures, simply having families create a monitoring form so we can get a really accurate picture of what's going on for the child. So for each day, Monday, Tuesday, Wednesday, Thursday, Friday, track, the number of hours that they were in school and their distress rating on this kind of fear thermometer, like a 0 to 8 rating scale of how distressing was the school day. And so then we can start to develop patterns. Is this a child who really struggles with anticipatory anxiety in the, right in the morning before the school day? But then as the day goes on, like once they're in, things feel better? Or is this a kid where the anxiety increases throughout the day? And again, just having a clearer picture about what's going on can help you to make the right recommendations for, for what to pursue next. Okay. So why do kids refuse school? We always want to think about, like, what is the function of the school refusal for this child? Generally speaking, we can kind of categorize school refusal into one of 4 functions. So the first would be, I avoid school to avoid general school-related situations that cause distress. So school just in general makes me feel uncomfortable. Number 2, to escape school-related social or performance situations that cause distress. The third one would be to get attention from significant others or caregivers, so it would be really attention maintained. And the fourth one would be to get to do fun activities outside of school. So, I want to present some, I want to talk a little bit about examples of what each might be. I want to present some vignettes that illustrate these concepts in action, and then really think about how we can develop interventions that would be targeting the function. All right, so first we'll talk about refusal due to these kind of negative reinforcement. So to avoid general school-based situations that provoke negative affect. So again, this is more common in younger kids. Sometimes kids can't identify specifically what's distressing them about school. So there may be a number of situations that cause distress or discomfort. It just could be, I feel uncomfortable in the bus ride or in the car ride to school. I'm afraid to be late or to miss the bus. I have fear of this kind of unstructured time, like lunch or gym makes me feel really uncomfortable. Kind of broad-based concerns about peers, fears of fire drills or unexpected situations. I was working with a little one who last school year, there had been a water main break in the school, and then a lot of fears of school avoidance or fears related to school this year because of, like, what if this happens, what if that happens, what if there's another water main break, what if there's a fire. And again, because these kids, this general school-based avoidance tends to occur more often in younger kids, you're going to see an increase in somatic complaints in this population, often in order to avoid. So yes, sometimes actual headaches, nausea, stomach distress, but sometimes kind of feigned illness in order to be able to go to the school nurse or stay home from school. So to escape aversive school-based or social activities or evaluative situations. So this is more common in older children and adolescents once the kind of social anxiety, the sort of impact of my peers becomes really preeminent in my mind. So these are the socially anxious kids, the kids who are really concerned about perfectionism, worries about how they're perceived by others. Unstructured activities like lunch or PE may be harder for these kids. These kids may have trouble turning in assignments if they're not perfect, or trouble reaching out for help or getting extra support. So avoiding school is really to avoid having to be on the spot, either socially, academically, or in a performance-based situation. So then we turn to school refusal behavior that's reinforced via positive reinforcement. So to gain to gain attention from significant others or caregivers. In this presentation, the child actually may be less anxious in the school setting. So maybe once they get to the school, they are okay, and they may even be fine to attend school if their caregiver is with them. But you will see a lot of behavior problems and attempts to avoid school, tantrums, non-compliance, physical complaints, refusal to get out of bed or prepare for school. And again, this is often, but not always, associated with separation anxiety. But this is where kind of giving a lot of feedback to the parents for how they can change their behaviors in order to remove the reinforcing nature of their attention is really important. And then finally, the access to tangible reinforcers outside of school, or the chance to do fun activities outside of school. So, these kids may not actually really feel a lot of anxiety or distress in the school setting. Maybe school is at best, or at worst, I'm not sure, seen as boring. But they want to miss school because they don't want to be at school. They want to spend time with friends, romantic partners. They want to go to the mall. They may have some legitimate complaints about school, where like maybe they feel like the school is unsupportive or boring, or this pattern is more closely associated with more truant behavior. Not all kids in this pattern show delinquent behaviors, but this piece does often go hand in hand with more truancy and avoidance of school that's not associated with with anxiety, with depression, and often seen in families with high conflict. All right, and then you get the refusal for multiple reasons. And I think that when we are doing more of like a kind of a case conceptualization, sort of functional assessment of the kids who we see in our program, usually there's a heavy proportion of this that's driven by negative reinforcement. Kids are avoiding school or kids aren't going to school because they're trying to avoid or escape distressing situations, but there tends to be this additional, like these kind of secondary gains. There's attention from caregivers. There's other sort of tangible reinforcers that they get as a function of avoiding school. So we really want to think about all of these different components. All right, let me just check our time here. Okay. So I'll go through a couple examples and sort of highlight what we think might be reinforcing here. So Troy is a 9-year-old boy who wakes every morning complaining of a stomach ache and insisting that he does not want to go to school. He whines, cries, and procrastinates getting ready, resulting in high conflict with parents each morning. He does eventually get in the car and get to school, and teachers note that he's sullen and tearful throughout the day. His mood improves shortly before pickup, and he seems more like himself in the afternoon and early evenings. However, by bedtime, he's often in tears in anticipation of the next school day. He seeks excessive reassurance from caregivers about the following school day, leading to a delayed bedtime onset and overall disrupted sleep. Troy cannot articulate any particular reason for his school-based distress, instead just insisting, "I just hate school," when asked. All right. So if we were to think a little bit about, what's the function of these behaviors, we're seeing a lot of just avoidance of general school-based situations. So we see the somatic complaints, kind of being sullen or tearful, not really being able to articulate what it is that leads him to not want to go to school. But then we also see that there's, an interactive piece here with caregivers. So getting excessive reassurance, this is probably one of those kids who, before he goes to bed, has, half an hour of one-on-one time with a caregiver, talking through, how am I going to get through the next school day? And even though the tone of that conversation may feel distressing, that is actually probably reinforcing the fear, because the secondary gain there, not through manipulation, but just simply this child is getting a lot more attention from parents when he's struggling with anxiety and school refusal than when he's not. So we'll really want to think a little bit about not only like how can we alleviate his distress around school, but how can parents respond to him in a different way so they're not inadvertently reinforcing the fears and the complaints and the reassurance seeking around school. All right, so Seneca is a 15-year-old female who identifies as queer. She loved school before the pandemic, but has struggled to transition to high school in person. Seneca reports believing that she doesn't fit in her new high school, that she's being judged by others, that she feels overwhelmed by the size of the high school. In addition, she witnessed another student vomit in the hallway on one of the first days of the school year and now endorses fears that she'll vomit in front of everyone if she has to answer a question or give a presentation. She reports nausea and panic symptoms most mornings and has begun to restrict her eating behavior before school to avoid provoking more nausea and or vomiting. She misses 2 to 3 days of school per week. If she does attend school, she often goes to the school nurse complaining of nausea or panic, and her parents will pick her up. So what we're seeing here, again, this is school avoidance for multiple reasons. We see, this is a kiddo who's got, discrete anxiety related, a discrete anxiety related presentation. There's some social anxiety going on. It seems like there's a, kind of vomit phobia that, may or may not be subsumed under social anxiety, but clearly a fear of vomiting and, change in behavior to try to avoid fears of to try to avoid actually vomiting. Then, of course, if she's not eating enough, she's going to feel nauseous, which she'll probably misinterpret as more anxiety in the school building, which is going to make it even harder to attend school. So there's a lot going on here. A little bit of avoidance of just kind of general school-based situations, just feeling like school's too much, school's overwhelming. And then we've got the positive reinforcement of if I go to the school nurse or if I complain of panic, I get to go home. So that's going to be, she's getting this attention and she's getting, because her parents are coming to get her, they're sort of allowing that negative reinforcement to perpetuate. And they're also providing, direct positive reinforcement by coming to get her. All right. So example 3, Marissa is a 12-year-old girl who's avoided school entirely for the past 4 months. Her parents highlight a long-standing history of generalized anxiety disorder and note the onset of depression 6 months ago, accompanied by passive suicidal ideation. Her mother's taken a leave of absence from work to attend to Marissa's needs. Her parents report that they attempt to get her to school every morning, but note that she often will not get out of bed until close to noon. When she reports elevated depression in the morning, she's often curled up in a ball in her bed, and one of her parents will lie in bed and rub her back. On other mornings, Marissa complains of stomach aches or menstrual cramps, for which her mother gives her a hot compress. Her mother expresses that she feels that Marissa has no joy in her life. And so when she's awake, her mother encourages joint activities, including watching TV, baking, or doing crafts. So here what we see are these, very well-meaning attempts to reduce Marissa's distress by caregivers, but that may be ultimately contributing to more school avoidance. Right now they're in a situation where, Marissa's school attendance has just school avoidance has just taken over the family. She's got, but think about kind of all the things that she's sort of getting from this set of circumstances. That's not to diminish her anxiety and her depression or the suicidal ideation, but she's home one-on-one with her mother every day. If she expresses, physical complaints, she's getting a lot of, lovely attention, hot compresses, back rubs, things like that. And then she also has the opportunity to do these lovely joint activities with parents. So she's accessing these tangible reinforcers. So this is really common in a lot of the families that we're seeing, where understandably, when you're a parent and your little one is in distress, regardless of how little they are at the time, you want to help, you want to decrease the distress and soothe them. But it's going to be really important for the families to understand, how are you actually maybe inadvertently making this problem worse? And how can we start to pull back some of these positive reinforcers that may be making it even harder for Marissa to get to school? Okay, and finally, Finn is an 18-year-old male and a high school senior whose parents report that he struggled with the social isolation of the pandemic and who was eager to return to in-person activities. However, his parents now report inconsistent attendance, frequent tardiness, and reports from school that he's often leaving early. Teachers also report multiple incomplete assignments. He and his parents have frequent volatile arguments around school attendance. He drives himself to school, but parents are aware that he has either skipped school entirely or left early in order to spend time with an older peer who recently returned home from college. Finn, this is Finn, often refuses to get out of bed in the morning and is often still in bed when parents have to leave for work. On days he will not attend school, he reportedly spends much of his time playing video games at home. So most of this is more in line with the kind of truant behavior. Most of this is due to, the access to tangible reinforcers outside of school. All right. So I will move on and talk a little bit about, kind of how would we address some of these issues. And so first I'll talk about interventions for negatively reinforced school avoidance. And then I'll talk about interventions for positively reinforced school avoidance. So, for kids who are avoiding and escaping, first and foremost, psychoeducation about emotions and sort of normalizing the emotional experience. So much of the time when kids feel the physiological symptoms of anxiety, they can catastrophize this. It's like, oh my gosh, something is really wrong with me here. So giving them the knowledge and the language to be able to talk about their symptoms, to recognize that anxiety symptoms peak and then they diminish over time, that your body wants to return to homeostasis, and that, the difference between the number of beats per minute that your heart will beat when you're having a panic attack is still so much lower than when you're having a heart attack. You're not having a heart attack. And that, letting them know that their body, their anxiety response is doing exactly what it was evolved to do, but it's kind of like going off at the wrong time. It's like a fire alarm that's going off at the wrong time. We do find that this knowledge of the association between avoidance and anxiety is really, really powerful. So for kids to start to understand, the more I avoid things, even though it helps me in the short term, it's actually going to make things harder. Thinking about building on kind of future goals and desires. You're a person who you really, really want to be in the school play next year, when that's open to all 8th graders. In order to get to 8th grade, then we're going to have to tackle attendance in 7th grade right now, right? So, how can we help you now so that you can do the things you want to do in the future? Because the more you avoid, the less likely it's going to be that you're going to be able to get there. It's great to give some instruction in coping skills. So any relaxation techniques, some mindfulness strategies, or cognitive restructuring. I do find that it's really important to set expectations for coping skills. A lot of times, kids will learn diaphragmatic breathing, and then they'll be anxious, and their parents will say, use your skills, and they'll be like, my skills don't work. But I think that a lot of that is because of a mismatch of sort of expectations and reality. Coping skills are designed not to alleviate anxiety entirely. It would be great if you could do diaphragmatic breathing and not feel anxious at all, but that's just not going to happen. The reason for coping skills is if your anxiety is at an 8 out of 10 and you can do some diaphragmatic breathing and bring you to a 6 out of 10 so that you don't leave school, that's what the purpose of coping skills are. And so I think that if kids and parents are looking at coping skills as like, a tool to help you keep meeting your goal rather than a way to eviscerate negative emotions, then families are more likely to use them and to good effect. And then really important, to increase school attendance through graduated exposure. So to illustrate this, I'm going to go back to my example of Seneca here, and show you all an example of a graduated exposure hierarchy of what we might do to tackle some of the issues that she's got going on here. So you can see here, this is a fear hierarchy that lists exposure tasks. On the left side is kind of the subjective units of distress, the kind of SUDS rating. So asking Seneca, if you were to eat a small breakfast in the morning before school, on a scale from 0 to 10, how anxious would that make you? Okay, so that's a 2. So we'll put this on your fear hierarchy there, and we'll probably start there. What would it be if you raised your hand during math class and deliberately answered a question wrong? Okay, yeah, that's an 8 out of 10. So that one's going to go up here. And so you kind of identify the areas where anxiety is interfering, and then come up with these like bravery challenges or exposure practices that we'll ask kids to do gradually. So you can see watching videos of vomit is something lower on the hierarchy. Again, that's to try to get more exposure to the vomit phobia, to feel like, okay, that's really gross and I can tolerate watching it. Then you see up number 7, watching vomit videos after having eaten. So we're kind of upping the ante then. And you can see also that we've built in some concrete exposures to being in the school being in the school itself. So going to the nurse for 15 minutes only and returning to class. So anxiety is pretty high there. Going all day to school without going to the nurse's office or being picked up, that's a 10. So we're not going to start right there. We're not going to say, all right, Seneca, day one of, cognitive behavioral therapy targeting school avoidance and anxiety, you just got to go to school. We're going to lock you in. You can't come out. We're going to start slow and help the child build some mastery in fighting back against the anxiety symptoms that they're experiencing, and then working up to being able to be fully engaged in school. All right, so let's think a little bit about interventions for positively reinforced school refusal. So, number one is reducing the caregiver accommodation of school refusal, or decreasing attention from caregivers. We also take an exposure model approach towards this. So, for example, we might recommend something like, okay, because we've explained to the child, when you text mom and dad when you're at school and they respond and you get into the spiral, does it actually help? Does it actually make you feel like you can stay at school all day? No, it doesn't really help, right? So what we're going to do to start is, if you text, your parents are going to wait 10 minutes before texting you back. And, or there you are going to ask for a pickup and your parents are going to ask you to wait for 30 minutes before they ask if you still need to pick up. And oftentimes, because anxiety goes up and down, with more time, sometimes you can kind of check back in with the kid later and they're like, actually, I'm okay. I think I can get through it. But we need to kind of explain to the kid what their parents are going to do. We don't want to reduce reassurance. We don't want to reduce parental accommodation without the kids understanding that that's what's going to happen. We also want to help educate parents about kind of how they can use their attention to reinforce the behaviors that they want to see more of. Often what we find is that parents of anxious or depressed kids are giving their kids so much more attention when their kid is struggling than when their kid is not struggling. It's a kind of like a let sleeping dogs lie here. Oh, they went to school today? Okay, don't say anything, like don't ruffle the feathers. But then when there is distress, then, now come the big guns. Mom, dad comes home from work, mom takes the day off, get lots of attention, the back rubs, all of those things. So we really want to help parents to bring their attention to when the child is, doing the things that we want them to do, engaging in developmentally normal desired activities, and starting to remove their attention from the times when, when the behaviors and the are less of what we want to see. It can also be helpful to increase structured in routines. So instituting a morning routine, improving sleep hygiene, and coming up with a clear plan with expectations for school refusal, building in tangible rewards or consequences for non-attendance. So in the interest of time, I won't read this verbatim. I hope that, you all can feel free to look through it on the slides, but this is just kind of an example of something that we might do. So coming up with a concrete plan for getting out of bed and sort of what the reward would be. What she earns if she's able to spend a half day at school, a full day at school, kind of how to build in this rewards plan to positively reinforce more time in school. Then if she does not attend school, this is really where we're trying to peel back all of those positive reinforcers of being in the home. So she's got to get out of bed. She can't stay in bed until noon. If she's not out of bed, parents actually take the sheets off the bed without saying anything. No arguing back and forth. The without saying anything here is key. Again, we're trying to reduce parental attention to the behavior. So really teaching parents to have their poker face, not engage with her yelling if they're saying, if they take the covers off, that's really key. Sometimes we do have parents install a doorknob, change the doorknob so that they can lock the child's room, especially if they're not able to be there during the school day, so that the child cannot go back into their bubble. Disable the Wi-Fi at home, no phones, doing academic work at the kitchen table, minimal interactions at home. So between the hours of 8 o'clock and 3 o'clock, or whenever the child is supposed to be in school, the home should be structured as much as possible to mimic the school setting. And it should be more boring and it should be more uncomfortable, because otherwise, why would the child be motivated to face their fears and go to school? Again, here's a little bit more of a behavior plan for the parents responding to the child requesting for a pickup. So really validating what's going on, giving some encouragement, offering some coping strategies, and then turning off the attendance faucet. And then setting up criteria for when non-attendance is acceptable. All right, so all of these strategies are things that we as psychologists and my team would be doing in a behavioral health setting where we're meeting with the child, once or even several times a week. And I recognize that that's not a luxury that you all have with your patients, in a primary care office. So I wanted to try to emphasize the things that I think might be helpful within the shorter term setting. So first, the importance of monitoring and assessment. So encouraging families who are reporting school refusal in their children to start by kind of getting curious about what's going on, being a detective, figuring out exactly when the behavior is happening, why it's happening, and even for parents, encouraging to think about, what's your response to the child's non-attendance to help pick up on what the parent may be doing that may be inadvertently reinforcing the behavior. And then kind of brief interventions that you all may be able to do in the office. Again, that psychoeducation about the association between anxiety and avoidance. Kids are smart. Parents are smart. They want to learn about this stuff. And so, helping them to understand that this is a pattern, this well-meaning attempt to minimize child distress in the moment helps in the moment, but it actually makes things worse over time, can set up the expectation for kind of changing some of these behaviors. Brief instruction in coping skills like diaphragmatic breathing, progressive muscle relaxation, or mindfulness techniques. Again, with the caveat that these coping skills just help you to cope. They're not going to alleviate all anxiety and sadness. Helping to brainstorm rewards and consequences for school attendance with the family if they're open to that. I think that physicians can be really helpful in talking about sleep hygiene or helping the families come up with a behavioral sleep plan. Because if the kid is going to bed, the kid has their phone all night, it's not going to bed, they're waking up groggy, it's going to be a lot harder. It's harder for us to do all of the things that we need to do when we're not feeling well. So starting off with sleep hygiene, coming up with a good routine can be super, super helpful. Kind of for the kids for whom school avoidance is, maybe in the future, but not necessarily there, kind of a way to address the Sunday scaries with families are to, plan a fun activity for Sunday during the day, to help get focus off of fear of Monday, and then to keep Sunday night quiet and relaxing, encouraging kids not to focus on Monday. Only to focus on Monday, not the whole week, and to plan a small reward for Monday after school. And then referrals to behavioral health specialists. Let me just briefly run through. I tried to put in as many resources, Massachusetts-based, especially Boston-based resources. So we have for outpatient psychotherapy. These are all centers where they would take this kind of exposure-based and behavioral parent training approach. For kids, for families where there is a lot of parental accommodation of school refusal, it's really important to get the parents involved. Just sending your kid to an outpatient psychologist or psychiatrist is often not going to be enough. So outpatient parent coaching and guidance, you can see here on the bottom, can be really key. Partial hospitalization programs, these are mostly for when kids have such entrenched avoidance and co-occurring depression that they're not able to actually get out of bed or to engage with any outpatient treatment. So then that we would recommend a higher level of care. These are 3 great resources for parents who are struggling with kids with anxiety. The last one I've drawn heavily from, as I mentioned, Chris Kearney's work for this talk. And I think that we're there.
Wow, wonderful. Thank you so much, Dr. Elkins. So we have a few questions that we want to ask you from the audience, and we'll see if there are more. So the first question, I think you addressed this already. You may want to say more about this. And this really speaks to the long waiting lists, nowadays for getting resources arranged, on the outpatient side, in the specialty behavioral health world. And just whether there's any other recommendations you have for what primary care providers can do in the interim for patients and parents. So I don't know if there's any additional things you can think of in relation to that.
Yeah, it's lobbying our legislators to make behavioral health more accessible. So again, I think those book resources, particularly the You and Your Anxious Child and then the Eli Leibovitz space program, give parents those books and strongly encourage them to read them, because I think that if so much of this work, is dependent on parents changing their own behaviors to make it so that children have to go to school. And I don't mean like hog tying your child and forcing them into the school building, but changing the ways that parents respond to anxious behaviors, anxious requests, and sort of expectations. And so often if we can get the parents to actually be thinking about school refusal from a different perspective by reading these books, it makes kind of addressing some of these challenges so much more accessible. So I know that nobody, who's desperately looking for help wants a book. And when there's long waiting lists, it's, I think it really is a great first step. We are recommending for families, get on as many waiting lists as possible. Just really make sure that you're not just holding out hope for like the one provider. Have the families check with their insurance providers about, what are their rates for outpatient reimbursement for out of network reimbursement for outpatient services, so that they're not having to rely just on clinics or practitioners to take their insurance. That can widen things a bit.
Right. I think that's a great point. And it does speak, I think that, the common theme here is psychoeducation. Just because I think that it can go such a long way when parents really get, it's almost like you're teaching parents to kind of resist, their sort of natural instincts in a way.
Oh, 100%.
So for them to learn about how their natural instincts to comfort and protect their kids from anxiety is kind of the opposite, in some way, of what will help, in terms of trying to prevent the avoidance from kind of proceeding. So the other question, actually, there's two other questions. One is, I feel like it relates to the issue that we talked about before we started, when we were having our pre-discussion about sort of the kids with behavioral issues, where it's sort of oppositional, defiant type of behaviors. And unfortunately, it's not such a clean interface, because kids with anxiety, when they're, trying to avoid things and they're deathly afraid of something, they can be very, very challenging in terms of defiant behaviors, and those defiant behaviors can sort of take on a life of their own. But this particular question is about kids who are on sort of homebound education plans because of school refusal and not wanting to do their remote learning. Which might be uncomfortable for them in all kinds of ways, and what can providers do to advise parents who are really struggling with getting kids to do their schoolwork when they're at home, even though they're probably not supposed to be at home, but they have to be.
It's so hard, when there are kind of circumstantial restrictions that make it so the kids can't get out and live life and develop coping skills, and then they're refusing to do what they need to do. So again, this would be where working with a parent guidance person or a parent coach to help parents kind of almost do like a chain analysis of like what the child's behaviors are and then what the parents' behaviors are in response, figuring out like what is the child accessing outside of, like where's the child's motivation? How can we develop a behavior plan that rewards engagement with school, and where, not fulfilling their requirements result in natural consequences. So I think really it's parent-led behavior plans, and again, coming up with something that is individualized, right? I don't want to make any recommendations for, any concrete recommendations without knowing the individual child and their context. But that's where working one-on-one with a parent guidance person to help get some recommendations for, like, what do I do for my child here to really kind of shift the needle.
Great. The last question, Dr. Elkins, is I think this is a quick one. It's about when schools ask parents to pick up their kids if they come to the nurse's office, they're in distress. Parents know, that it's not, or hopefully they know that that's really not always in the best interests of the child. And so the question was about whether parents can and should refuse to pick up their kids. And obviously, I think that's fraught with all kinds of potential consequences around, power struggles with the school. And, and the DCF. So what are your thoughts about that, and how pediatricians should respond to those kinds of questions from parents?
Yeah, so I think taking kind of a multidisciplinary approach to this. So pediatrician, parents, school personnel coming together, identifying, that this is a child who's struggling to stay in school for the whole day, that it seems like, kind of based on some functional assessment, that actually leaving school early is reinforcing the avoidance. So how can we gradually switch this around? And then kind of coming up with something where everybody agrees that, if the child is insisting, I need to go home, school personnel will reach out to parents, kind of what the length of time is before the school personnel reaches out, what the child can be instructed to do as kind of to show that they're working on it, like to do a couple coping skills before, in order to make reaching out to parents then something the school agrees to do. Once the school reaches out to the parents, what will the parents do? What does the child need to do before the parents will come pick them up? So again, I think this is really, it's hard for people who care for children because it involves a lot of out of session collateral. And I think that's usually going to be the best way to go. Try to get everybody on the same page, including the kid.
Having a plan in advance for those. Absolutely. Well, that was so wonderful, Dr. Elkins, and thank you so much for sharing all of that. Your engagement and questions, and we'll see everybody next month. Please don't forget to fill out your survey at the end. But thanks, everybody.
Thank you all. Bye.
Take care.